defined, but the DS encompasses the non-standard sleeve, a non-standard mounted bypass. Do you think that these are identical in their mechanism?
Well, as I said in the beginning, I don't know. There has not been any real study of head-to-head of biliopancreatic diversion switch. I think the biliopancreatic diversion is more standardized for two reasons. It's done in Europe by a few people, and most of the publications come from Dr. Spokonarmi. Whereas in the United States, duodenal switch is done by many more people. And many have entirely different ideas on how to make different lengths, the length of the trauma channel, the length of the biliopancreatic limb, etc., and so on. And nobody has really provided solid data to say this way is believed is the best. And then there are technical differences, as you very well know. When you started doing gastric bypasses, you were unhappy with the leak rate, so you could hand-sew your anastomosis. Now, does that make a difference? It may make a real difference in terms of complications and safety. We now do them open, laparoscopically, and robotic. Does that make a difference? I don't know. But there are no real data because there are so many variations.
Thank you very much. It's a pleasure to be with you. I don't know if I have to say thank you to the moderator, because to say something about this after these two big gurus of the obesity surgery, metabolic surgery, I think for me is sometimes is to be pretentious, or you know, I don't know. Thank you again. It's difficult to talk about because I absolutely agree. If we are talking about patients with type 2 diabetes or super obese patients, we have to do a real, we call in our hospital real surgery. Real surgery does not include restricted procedures. However, as I mentioned before in the previous session, our principal target is to try to have the most important thing for our patients is the safety. You know, I think it's ridiculous, you know, everybody, you that play the difference between biliopancreatic diversion to the switch and the sleeve gastrectomy. The sleeve, I think just to know something is, for me, is surprising. Many people is doing a sleeve, probably because it's a simple operation, but I don't understand why people is using this technique in so different varieties, from the distance from the pillars, the bougie, etc. That means something for me, for a quite simple operation, at least in a technical point of view, sounds, I repeat, ridiculous. But it's no doubt, we are surprised because we study a lot at the beginning when we started with the sleeve gastrectomy in my hospital. It's no doubt it's a changes in the gastrointestinal transit, but people is talking about is more rapid or slow transit. It's no doubt it's a restriction. Again, we can discuss what kind of restriction, because we saw patients previously operated with a big fundus, and that is the reason because I think it's important, you know, to take into account that it's very important to have experience to do this kind of procedures, even the simple procedure of a sleeve operation. We were very surprised. We have hormonal changes similar to another procedures like a gastric bypass, and is no doubt we improve comorbidities, and the weight loss is quite, at least in midterms, is quite good. In terms of weight loss, there are authors from, for example, from Belgium, the group of Himpens, published more than 5 years ago with very good results, better results than banding procedures. And when we were very surprised when we published in 2006, 2007, our results in terms of the glucose metabolism in a few patients that we studied. But we confirm after a midterm means only 12 months, and we confirm now with 2 years follow-up. But there are several authors around the world. They have similar results that we had in terms of resolution of comorbidities, hypertension, diabetes, hyperlipidemia, or sleep apnea, with good results in weight loss. If you compare laparoscopic sleeve gastrectomy with gastric bypass or banding in type 2 diabetes, is no doubt similar results, maybe less, maybe poorer results comparing with duodenal switch or biliopancreatic diversion, but similar results, at least in this paper published 2 years ago in gastric bypass comparing with the sleeve gastrectomy. But maybe if you go to try to reduce morbidity and mortality, more than 10 years ago, the group of Michel Gagné published about a small group of patients with only 40 patients, the 50% of them with BMI less than 65, but 60% of them, 16 patients, BMI more than 65. If you can see here in the figures, the morbidity, the major morbidity is very important, it's quite important, and the mortality in patients with super obese patients is more than one, means it's 2% in these patients. And the mean excess weight loss is 65%, a similar result in other techniques in a year follow-up. If you compare studies laparoscopic versus open biliopancreatic diversion, at the beginning maybe, with no experience that Professor Bacho presented now with zero mortality, etc. As you can see here, now at the moment, even with some slight differences, we can say laparoscopy could be one of the best techniques to do this procedure. The concept of two-step procedure in super obesity was introduced in literature by many authors, but I think the group of Michel Gagné, I think they have a lot of experience, at least in the United States, and it is important because it's tried to reduce mortality, and they achieve a mortality of 0% in a super obese patients. However, the question is how many patients going to a second step procedure after a sleeve. In a randomized clinical trial comparing laparoscopic gastric bypass with laparoscopic duodenal switch in super obesity, if you can see here, there are slight differences that we can say is a safer procedure to do, easy procedure to do in a gastric bypass than duodenal switch patients. However, the BMI and excess weight loss at 6 months and a year was a difference in both groups. If we study more than 300 patients operated in our hospital with a BMI of 50, majority of them female, and age around 40 years old, you can see the weight loss in 48 months is, I think, is very good. If you can go to the excess weight loss, is similar to other procedures like gastric bypass, 73%, 2 years follow-up, 36 months is 65, and then we have only few cases with more than 48 months follow-up. In the BMI, I think it's important. You can go to 36 months in our patients is a good result. However, these patients, the mean BMI is still 34. In comorbidities, the hypertension is similar results to another gastric bypass procedure, probably poor results comparing with biliopancreatic diversion. In dyslipidemia, similar results, and sleep apnea again, and maybe the most important is type 2 diabetes. We have 70% resolution in our series. However, if you go to the initial BMI, if you compare patients with BMI less than 40, BMI between 40 and 50, and more than 50, yeah, similar results in a follow-up of 13 months. However, at the beginning of the follow-up, in 4 and 8 months, we have better results in patients with lower BMI. In summary, I think laparoscopic sleeve gastrectomy has a good result, at least in short and mid-term. Our study in 36 months is similar to other techniques such as laparoscopic gastric bypass. We have better results in patients with BMI less than 50. We have higher complications in super-obese patients with duodenal switch, and that is the reason because we think we can start to do a sleeve gastrectomy in these patients. And laparoscopic sleeve gastrectomy maybe has an advantage from the gastric bypass, because if the patient regains weight or has another time complications, you can make another technique like biliopancreatic diversion. And in conclusion, in super obese patients, our technical difficulties choose the decision to make laparoscopic sleeve gastrectomy. And in the follow-up, you will see if a definitive procedure or it's a simple first sleeve technique to do after a biliopancreatic diversion or duodenal switch. Thank you very much.